It's great to be with you all today. Thank you, David, for the introduction. As he mentioned, I work for the Tennessee Department of Mental Health and Substance Abuse Services in the Office of Prevention and Early Intervention. So today I want to talk to you a little bit about both kind of the data side of what we're seeing in the state of Tennessee and some of the state's responses. And so one of the things that I want to highlight as we're talking about all of this is I'm going to highlight some of the state programs. Some of you all may be involved with those. Many of you may not be, and that's okay. But all of this is about the work together. So the state has some contributions to that, but so many of you in the room are getting up every day and doing this work. So I'm really excited to share with you, as David said, some of the hot off the press data. I received it at 11 o'clock last night. So excited to share some of the data. I will also preface with saying I'm not quite as familiar with it as I usually like to be when I present it, but we'll roll with it today. So for the next 50 minutes or so, you have the pleasure of hearing my voice and hopefully some good information along the way. We're going to talk about the landscape of substance use among youth here in Tennessee. We'll also talk about overdose here in Tennessee, and then look at evidence-based strategies for substance use and overdose prevention. So when I present for the state, my notes are in one place, the slides are in the other. Just an overview of where this fits in with our overall mission and vision about collaborative pathways to resiliency, recovery, and independence. So we really see the prevention piece in that resiliency part. And as we transition into the more harm reduction sorts of works, we see that as kind of that bridge into the recovery aspects as well. And then the overall goal of seeing people thrive. We're not here to survive, we're here to thrive. So I'm going to start off talking a little bit about some of the youth substance use and some of the efforts around that. So I'm going to talk about this TN Together student survey. Anyone in here familiar with that? No? Okay. A couple people in the back. So what I will preface by saying is that this survey is administered across the state with 8th, 10th, and 12th graders. Shelby County does not participate in it. They've got their own stuff going on. I don't have that data, but I do have the statewide data that people who understand stats a lot more than I do say it's pretty good as a good picture for what's happening across the state. So it occurs through our office and lots of community partners. We are currently in our 4th administration of it here in 2024-2025 school year. And as I said, it surveys 8th, 10th, and 12th graders. So it's a fairly robust survey. It takes about 15 or 20 minutes for students to complete and looks at a variety of metrics related to youth behaviors, attitudes, and social norms related to substance misuse, and then additionally some on emotional health and wellness. You can see there are quite a number of metrics on this today. I could do a whole presentation on this. We're not going to do that, so I'm going to highlight a couple of them and then also give you the link that you can look online for additional resources. So because it's the Opioid Summit, I'm going to highlight some of the information on prescription drug misuse among Tennessee youth. So a couple key points here. So about 3% of students are reporting misusing prescriptions in the past 30 days, but of those, 42% or almost half reported 6 or more days. So we would define that as high frequency use. So what does that tell us? That means that there are youth out there using, and that those are high-risk behaviors. The other piece I want to highlight here is that the age of initiation is the youngest of the substances that we measure among prescription drugs and cigarettes. So what does that tell us? That tells us that those are accessible for people, for young people. It's why things like Drug Take-Back Day are so important, because the easier it is to get, the more likely they are to use it. So when we start looking at other substances, the illicit substances, you see those age of initiation go up because those tend to be harder for young people to get. So, some trend data. So you can see on the graph the 5 substances that we measure: prescription drugs, alcohol, marijuana, cigarettes, and tobacco, and vaping of nicotine. So again, because we're kind of focusing on the opioids today, what we see is that the past 30-day use of prescription and marijuana fell between the 2018-2019 school year and the 2020-21 school year, and then we see another small uptick in the most recent administration, but we are still below where we were in that first administration in 2018-2019. So there's progress there in terms of lowering that early age of initiation and early use of prescription misuse. Okay, so as we look at the data over time, another thing to think about that's a key part of prevention effort is the perception of risk. So with young people, it can be really easy to say, it won't happen to me, it's not, a big deal. Those messages are part of what we counter with prevention messaging, helping young people understand that there are risks associated with their behaviors, and things like starting prescription misuse early has long-term consequences. So we see that there is an increase in young people's perceptions of the risk associated with misusing those over time. So there's a ton of really fabulous data that you can dig into kind of in these infographics on our website, if you want to get out your phone and pull that up. But they're infographics. If you're a data person, you can download data tables and crunch numbers and look at it there. So this is a great resource. Like I said, Shelby County does not participate, but we do have a pretty representative sample from across the state. So, anybody else trying to get that QR code? Okay, so I kind of framed up one part of the data that shapes the prevention work, and so I want to talk to you all a little bit more about what are some of the prevention efforts that are happening here in Shelby County, in Tennessee, and then also some resources that if you're interested in doing prevention in the context of your work, we'd love to have you join us with. So when we talk about prevention, they're kind of key factors. So who's familiar with risk and protective factors? Yeah. Pretty common thing. So when we talk about that, what are we thinking about? We're talking about risk factors that are preceding and are associated with higher likelihood of negative outcomes, where we think about protective factors associated with the lower likelihood of, let me make sure I get this right. It's really easy to get them twisted. Protective factors, characteristics associated with lower likelihood of negative outcomes, so those positive countering events. So oftentimes there's a framework around adverse childhood experiences. There's also a movement among people talking about positive childhood experiences, that there are relationships and interactions and opportunities and so forth that can counteract some of those adverse experiences as well. So when we talk about prevention, who do we focus on? What does that look like? So I think one of the key parts of understanding prevention is that recognizing that half of all lifetime cases of mental and substance use disorders begin by age 14 and 3/4 by the age of 24. So what does that tell us? That's a very formative period in both kind of social and biological timeframes. And so when we think about prevention, one of the ways that we can be very proactive in that is pushing out that age of initiation longer and longer, and hopefully preventing it altogether. But knowing that the more we can delay that, the less likely it is to develop into a substance use disorder. We also recognize that those decisions about how substances, whether someone's going to use substances often happen in those teen years, and then we see lots of higher use during that 18 to 25 young adult period. So when we talk about where do we go with that, what does that inform us to do? It talks about why it's important to do that with younger students before they're faced with those choices, understanding the risks, understanding what could happen, and starting to lay that groundwork early on. So I'm going to talk a little bit about the continuum of prevention. There are several models out there. This one is the Institute of Medicine's continuum of services. So when we talk about promotion strategies, those are kind of those big picture strategies, environmental conditions for positive behavioral health changes. Then we move into universal prevention. So that's preventing or reducing the vulnerability in a general population. So the work that we are all doing here today is universal prevention. It is people who are not necessarily at higher or lower risk, but we're getting good prevention out to the general public. Then we start moving into selective prevention, which looks at people who have a higher than average vulnerability. So one of the things that you may see, for example, in youth prevention is if you have a family member who has a substance use disorder or is incarcerated or other things like that give those higher likelihood, then we start talking about those as selective interventions. And then the last one is this indicated prevention, which is where the ropes and the harm reduction sphere kind of fall in. So these are individuals who have demonstrated the behavior, and we are working on prevention efforts with that population. So as you can imagine, the types of strategies, the needs of those populations are going to vary from group to group. So when I talked about this move towards indicated prevention, and that's also in our framework is where the harm reduction comes in. So these are folks who in the world of substance use are using drugs, are using substances, and what are we going to do to meet them where they are and to improve health outcomes overall. So our work is really based on these kind of core principles, that we meet people where they are, that we recognize that not everyone is able to stop use where they are, and that there are scientifically proven ways that we can reduce harm and improve quality of life. So a couple of the key tenets that we talk about in our work are that we focus on a non-judgmental approach. So people who are using substances are going to encounter a lot of stigma. Sometimes it's internalized stigma, but it's also stigma from family members. It's stigma from friends, and it's particularly true in medical and behavioral health settings. And so when we step back from that judgment, that's when we have the potential to meet someone where they are and to work with them towards that change. We also recognize that behavioral change is an incremental process. So we don't go from 0 to 100. And even if the goal is moving towards that abstinence mindset, we recognize that you're not going to go from injecting many times a day to not at all, unless you're in a detox program, and that's that. But oftentimes for folks, we recognize that that's a slow process. If you're familiar with the motivational interviewing and stages of change, that's what that is based on. It is recognizing that those steps where you're starting to think about it, you're starting to take small steps towards that goal. We want to celebrate those. We want to recognize those, that those are often challenging for folks. And if our only lens is abstinence, then they haven't met that goal, even if they're working towards that. We also want to recognize that complex social factors increase vulnerability to substance use and those related harms. So I think we'll have a presentation later on about trauma. That's a key point there. And then we also want to recognize that we can't make anyone do anything that they don't want to do. And so we work with people to meet them where they are, educate and empower them to be the primary agents of reducing those harms. So this has been controversial. There's still a lot of people who are uncomfortable by it. It is different than a traditional abstinence-based model or a solely black and white primary prevention model. And so I just want to highlight the fact that in some ways this is not new or different. Who put their seatbelt on the way to today? Yeah. But I will say, having driven in Memphis this morning, it's a dangerous choice to get on the road. If we're looking through an abstinence-based lens, we would never leave our house because driving is dangerous. But still working on how to manage that. I'm not sure I want that either. But wearing a seatbelt. Who puts on sunscreen or a hat when you go to the beach? Also that, yeah. It is dangerous to be out in the sun. You can get a sunburn, you can get skin cancer, all of those things. We don't give up the beach. We take those steps to mitigate the harm. So I think it's important to recognize that when we talk about harm reduction, it really isn't just solely focused on needle exchange or naloxone. Like, all of us are practicing it and giving ourselves permission and the grace to recognize harm reduction as a part of many people's recovery journeys as well. The other piece that I think we focus a lot on in the work that we do is around language and stigma. So we talk about, I talked about the many places that people encounter stigma. And so we focus on what are some ways that we can use the language and that we use with clients, participants, community members, family members, but also the words we use and the words we choose change how we do that work. And so I love this quote. I've tried to figure out who it's coming from. There are a lot of different people that are credited with it, but watch your words, watch your thoughts, they become words. Watch your words, they become actions, and watch your actions because they become habit. So when we think about the work that we do in any setting, using language that supports and encourages people where they are is a form of prevention. So let's see. A couple to get your feet wet. So instead of saying an addict or a junkie, saying a person with a substance use disorder, a person who uses substance. Rather than using clean or dirty screens, that's a really common one in a lot of treatment facilities. Positive or negative toxicology, I think a next layer to that one is substance detected, substance not detected. So sterile or used needles instead of clean and dirty, that's also one that I think a lot of people have trouble letting go of. It just becomes so ingrained. Not using substances instead of clean or dirty, and then recognizing that a person living in recovery is a person living in recovery, not just an ex-addict. So if you're interested in some more resources on that, there are a couple great ones here. And I'm also happy to get you connected with those as well. But there's some work through the Tennessee Department of Health, Shatterproof, and NIDA, the National Institute on Drug Abuse, also has some great resources as well. So when I'm talking about some snippets into the work that we do from a prevention perspective, I'm going to talk a little bit about coalitions and individual-based programs. So who's familiar with the Memphis Area Prevention Coalition? Yeah? Okay, so that is the Substance Use Prevention Coalition here in Shelby County. They are supported through our state, but there are 46 of them across the state. The focus of those is underage and binge drinking, tobacco use, non-medical prescription drug and opioid use, marijuana use, and stimulant use. And their process uses an evidence-based model coming out of the public health world called the Strategic Prevention Framework. So if you are not from Shelby County and you're going, I wonder if this is happening in my community, it may very well be. Something like 80% of Tennessee residents live in a county with a state-supported coalition. So we have 48 of them. We've added 3 additional ones in the last couple of years, and we are happy to welcome them into our work. So these are prevention strategies that our coalitions use, but these are also prevention strategies that can be used in any context, any work. So getting information out there, alternative activities, thinking about community-based processes that can work together towards that, changes in policies, connecting with those resources, educating people about what's happening and what resources are available. So, oh, y'all, I've been like talking through my slides. Okay, coalitions. Goals of the coalition and the Strategic Prevention Framework, 48 county coalitions. Prevention strategies. Here we go. Now we're caught up. These are some examples of ones that occur some here in Shelby County as well as across the state. So drug take-back days, when I talked about young people misusing prescription drugs, how easy is it to find? Well, if you dispose of them when you're not using them, it makes it a lot harder for young people to get a hold of them. Things like Red Ribbon Week on campuses, awareness campaigns, partnerships with Department of Health for the TN Youth Summit, and then the Stashed Away trailer, which I think they've had sometimes at these summits as well. So lots of different ways to engage communities. This is one that I think I left in here to make sure that you all are aware. These are great resources for you to implement with your own family, in your communities, with your church, in your work. This is an evidence-based model designed by SAMHSA and has great resources in terms of conversation guides and conversation starters. And so while some of it is focused explicitly around underage drinking, a lot of the information and the ways that you can approach prevention with young people are really valuable, regardless of what substances you're talking about. So I'll just briefly highlight that in addition to the coalition work, the state supports the Tennessee Prevention Network. So those are individual-based programs that focus on a variety of different kind of protective and risk factors. So promoting community relationships, strengthening families, positive behaviors, connecting with mentors. So those occur across the state as well, and we have a couple here in Shelby County as well. Curriculums for that. Some of the most common ones are agencies are using the Botman Life Skills, Too Good for Drugs, the Sport Prevention and Wellness, and Strengthening Families. So I kind of focused there on the primary and a little bit into that selective prevention, and I'm going to move now into the harm reduction, the overdose prevention that we have going on. So as I said, I've got slides that are hot off the press, so I'm not as confident talking about these as I wish I was, but we'll do that together. So what I'm going to share with you is provisional data that's provided by the Centers for Disease Control and Prevention. We're still waiting on that 2023 data. There's a lot of internal stuff that happens. The delay on that is because there are a lot of layers of review. So it happens at the local level, and then it happens at the state level, and then it happens at the national level. So they want to feel pretty confident about the data that they're putting out, but it does mean that there's quite a delay. The other thing I will note is that we're going to talk about a couple of different data sources today, and those are going to be slightly different because there's differences. The epidemiologist that put these slides together talks about case definitions, but it's basically how are you sorting people, how are you categorizing for that? So some of the data, for example, if you look at state level data or CDC level data compared to local data, maybe the state measures overdoses for county of residence, whereas other agencies might look at the number of overdoses that occurred in the county. So recognizing that there may be a little bit of variation. The other thing is that most of what I'm sharing with you today is provisional data, which means that it's subject to change as that data gets kind of more finalized. So as David talked about, we're really hopeful and excited that we are seeing let's back up. We're talking about 2023 data for this moment. The red data is the Tennessee Department of Health data. The gray is CDC data. So again, there's a little variation in that, but this is what we've got to work with today. So we are really excited that we are anticipating having the first decline in overdose deaths from 2022 to 2023. As David said, it is not easy. There are a lot of you in the room that are doing work towards this goal. And what we're hoping is that we continue to see progress towards that. Generally speaking, what we are still seeing is that opioids, most notably fentanyl, and then stimulants, including methamphetamine, are still the primary drugs involved in deaths in Tennessee. What I will say is being here in Shelby County often has most of the cocaine-involved overdose deaths in the state. I don't have that statistic, but that's historically what we've seen. So the next slide I've got for you, again, the red is the finalized TDH data. The gray is the provisional CDC data. And what we've seen historically is this increasing proportion of overdose deaths of men. So you see that men have always overdosed and died at a higher level than women, but we see that gap getting larger over time. Okay, when we talk about age groups, that 2022 to 2023 period, we're expecting to see a decline for all of those large age groups. We are continuing to see the most overdose deaths happening in that 25 to 44 age group. So that's been pretty consistent over the last couple of years. When we talk about racial breakdowns in overdose deaths, statewide, Tennesseans still make up about 3/4 of the overdose deaths. Black Tennesseans make up about the 20% of the statewide overdose deaths. Keep that number in mind because when we talk about Shelby County, we'll see that that's one of the places that Shelby County is different. So, another highlight here. So historically, We've also seen increases in overdose deaths among Hispanic Tennesseans over time. So that's that small column next to the larger column. So historically, we've seen those numbers increasing, but like those other groups, we're anticipating seeing that decline that happened in 2023. So, okay, we're gonna pause there. So that's the provisional statewide data for 2023. You all are very fortunate to be here in a metro area in Tennessee, who also tracks and puts out provisional data that's current. So what I've done is I have pulled the data that the Shelby County Health Department has put out. So recognize that the data I just shared with you is 2023. The data that we are looking for here is provisional, so it is subject to change, especially the last 2 to 3 months. That's usually the lag that we see with this data. But look at this graph, y'all. So we are seeing that first data point at June 2023, and this most recent one in October 2024. Look at that decline, y'all. So obviously there's still a tremendous amount of work to be done. We are still losing far too many Tennesseans, far too many residents of your neighborhoods, your communities being impacted by overdose, but we are also really excited to see some changes there. Also want to give you guys a snapshot of what the demographics look like here compared to the rest of the state. So you can see that similar to the rest of the state, the deaths in Shelby County are the highest among those middle age groups. So the state data looks at 25 to 44. Here you see it's a little bit different, but again, we're seeing most of those overdose deaths happening in the middle of that group. The other thing to recognize is looking at the racial breakdowns. So this is one of the places that Shelby County is really different than the rest of the state. So when we talk about overdose deaths in the state as a whole, we're seeing about 20% of those being Black African American. When we look at this for Shelby County, we're seeing about 2/3 of the overdose deaths in Shelby County being among Black Shelby County residents. So again, there's a lot of work to be done here as well. Okay. So with that as kind of a framework, a context, I'm going to talk to you a little bit about some of the work that we are doing around overdose prevention. So who all has interacted with their ROPS, their regional overdose prevention specialist? A good number of folks. If you haven't, this is a great opportunity to learn what we do. So I oversee this program across the state. These are folks who, many of whom are in long-term recovery themselves. The focus of this really is training and education. So they're also the point of contact for naloxone fentanyl test strips. But we recognize that a lot of the work that needs to be done in our communities is about creating systemic change for places to be non-judgmental, to be where folks can go and get the help that they need. So if you're not from Shelby County, there is a ROPS that serves your area as well. That contact information is available online. So as I mentioned, they are also the contacts for our overdose resource kits, naloxone, which is the medication name for Narcan. Narcan's a brand name, naloxone's the medication name. And then we talk about these overdose resource kits. So that includes naloxone. So there are a couple of different kinds. There's a 4 milligram Narcan, 4 milligram generic, 8 milligram Clexato. We also distribute fentanyl test strips and more recently xylazine test strips. And then all of what we include has these resources in it. So we recognize that we meet people where they are, but we don't leave them there. And so that means, what else can I connect you with? How else can we make your life better? So recognizing that that's a key part of what we're distributing. It's not just the medication you use once and then, what else is happening here. So if you're interested in what's happening here in this state, we are really proud of the amount of naloxone that we have distributed. It is, when I'm on calls with many other states, I can tell you that Tennessee has been very proactive in this distribution. We started distributing in 2017. That was before I started, but the stories I have heard was nobody would take it, that it was so stigmatized to have it that people didn't want it. That is not the case. There's still a lot of work to be done, a lot of education, a lot of stigma reduction, but as you can see, we're seeing people wanting it and wanting to be a part of that change. Another thing that we are also really proud of is recognizing that we are getting it where it needs to go. That reported reversal number tells us that the naloxone is going to places where somebody is saving a life with it. It's not going in somebody's medicine cabinet or in their car and they're forgetting about it, that we're getting it where people can use them to be saved lives. We also recognize that that number of reported reversals is really fairly confidently underreported, because let me tell you, if someone has overdosed, they are not looking to call the state and tell them, I overdosed. So we recognize that that is probably much higher. This is just a brief overview about the ways that we are doing work in the community with naloxone. So continuing to expand points of access for naloxone and making sure that it's also in a lot of public buildings and places where someone can respond to that. So if you all are in a building or in an office and you don't have a naloxone kit, the ropes would love to come out and make sure that the medication is on site and that people know what they're looking for with an overdose and how to respond to it. So that's my shameless plug for call David and Tony and get them to come out. So this is the information for the ropes. There is also a website that we have developed that talks about naloxone, Narcan, and other kind of resources related to those sorts of programs, which I'd encourage you, if that's something you're interested in, you can either use a QR code or David and Tony can assist as well. The last thing I want to talk a little bit about is fentanyl test strips. So who in the room is familiar with fentanyl test strips? Okay, a few folks. Okay, so very briefly, illicitly manufactured fentanyl is what is really driving our overdose deaths here in Tennessee, but also across the state. It is not the patches that you get from your pharmacy. There are very minimal risks associated with that. This is stuff that is being made by amateur chemists and is extremely dangerous. It's also in many of the pressed pills. The DEA has put out a report that's like something like 70% of the counterfeit pills that are out there have a deadly dose of fentanyl. So this is really a key issue in our state and one of the main strategies that we need to use in order to address it. So it is 100 times more potent than morphine. There are more than 25 analogs, which are slight chemical variations. And as I said, they're involved in nearly 3/4 of overdose deaths in Tennessee in 2022. We're estimating that we'll see some similar rates of fentanyl in this year, in the last couple of years. So let's talk a little about fentanyl test strips. So you can see in the photo, they're very small, thin pieces of paper that you can use to test for the presence of fentanyl. So they became legal in Tennessee in 2022 with some restrictions on them. I'm not a lawyer, so I'm not going to go into those and give bad advice, but they are legal for that. There is a sunset clause on that, so if the legislature will have to decide if they're going to renew this in the upcoming legislative session. I've got some data that I think will show you that we feel really good about this as a harm reduction strategy here. So, and I think the key part about this, they're quick and easy to use, they're relatively inexpensive, and they're highly correlated with positive behavior change. So another way to say that positive behavior change is implementing harm reduction strategies with it. So we have worked with some partners across the state to collect survey results of folks who have received the fentanyl test strips and use them. And so we're pretty excited about the changes that we've seen. So among the participants that reported their use of them, 85% of them engaged in at least one positive behavior change or utilized a harm reduction strategy. So some of that's having naloxone there. It might be not using alone. It might be, we've even seen folks that are reported taking it back or not using it. So people are nervous about fentanyl, and they are using the information they get from these fentanyl test strips to make another choice. The other thing is that we recognize that folks are reporting that they feel better able to protect themselves. So when we go back from an accidental overdose. So when we go back to that core principle of harm reduction, being empowering people to be agents of change for themselves and their own well-being, this is also telling us that this is an excellent strategy for us to be doing. One of the things that we also feel is connected with this is that it's a great opportunity for engagement with service providers. So the fact that somebody is standing in front of you saying, I don't want you to die, here's a tool to help you, that's one more powerful message of worth and value that we build into our systems. So the other piece with that is that we see the numbers here in Tennessee are actually a lot higher than a similar study conducted in North Carolina. And I think that speaks to the robustness of the service providers that are getting these into communities. That it's not just a here's a baggie of them. It's a let's engage, let's get to know you, let's talk about strategies, let's do education with that. So we're extremely pleased with the success that we've had. We have also started providing xylazine test strips in the last couple of months and are anticipating seeing some similar results there as well. So the other thing that I think folks are often interested in is like, well, what does it look like? How much fentanyl is out there? Recognizing these are self-reported, but also this data is not the most current. It takes a little while for that data to come through. And so what we see is that a lot of folks who identify as stimulant users are using them. So are using the test strips. And we're really excited about that because what we know is that this is a 2022 number. In Tennessee, 77% of stimulant-involved overdoses also involved in opioid. So many of those stimulant-involved overdose deaths are happening in combination with fentanyl. Of those, 96% involve fentanyl. So the fact that folks are using those fentanyl test strips and testing those stimulants is one more way that we're working to combat that. The other thing to recognize is that when we ask folks, we give them a handful of test strips. And then we come back and say, how many of them? Some, none, or all. And so if you look at that, we see that there's a tremendous amount of fentanyl in the drug supply. And I would imagine that that data is even higher if we looked at the most current survey responses. So I hope these are helpful in terms of understanding a little bit about the data and the ways that we use that to inform strategies, and then also the data that comes out of these strategies. So we really feel like that we're seeing progress in a lot of ways, and that we're excited to continue doing that work. So I'm going to start to talk about some additional resources. Let's see, here we go. Okay. Has anyone visited our fentanyl webpage? No? A couple folks? Okay, excellent. So what that tells me is that it might not necessarily be out there in the most public way. I'm sure no one is really spending a lot of time digging through government websites. That's okay. But now that you know about it, I hope that you'll take advantage of that. So on this webpage, there are a wealth of resources and information. So you'll see the facts about fentanyl. They have that on the table at the Memphis Area Prevention Table as well. That's available online and is a great resource for you all to have available in the ways that you interact with communities. And we would love for you to print that out and to make that available. There's also a lot of misinformation out there about fentanyl exposure. So who's heard, like, if you touch fentanyl, you're going to overdose? Yeah, okay, it's not true. It has to get through your skin, it has to get to your brain. There are a whole lot of steps there. The state has put together some resources and guidance around that. So if that's a thing you're concerned about, you can read the stuff online. We also have free online fentanyl trainings that we would love to have you attend as well. The link to register for that is on the website as well. And then there are links to resources from the data from the Department of Health around overdose data as well. We have also recently published an emerging substances page. Right now that primarily includes xylazine. So who's heard of xylazine? Yeah. It's a non-opioid tranq, slows down breathing, makes overdoses more complicated, also contributes to, can contribute to severe skin wounds. And so there's some additional information there for kind of more public facing. There's also quite a robust Q&A for kind of a higher level, provider level resource of information about fentanyl or about xylazine. And then we also have some additional resources on nitazines. So the one that's most common people talk about is called ISO, and then there's a whole bunch of letters at the end. But ISO is a nitazine, that's an opioid. And so there's additional information about nitazines and their presence there. The QR code is there for our emerging trend, or our emerging substances page there as well. Still see a couple people working on their QR codes. Okay. And then I've got my contact information. I am a program manager that oversees the work of the ROPES, the Regional Overdose Prevention Specialist, and then the overdose reversal or overdose resource kits throughout the state. There's a team of fabulous folks that I work with that work with the primary prevention, the coalitions, and that Tennessee Prevention Network as well. Any of us would be happy to talk with you. That's my contact information, as well as my director, Anthony Jackson, who's the director of prevention and early intervention. So that is what I have. Do I see one of our folks to let me off the stage?